A 45-year-old woman arrives in the emergency room. On the surface, she presents with a light malar rash and severe fatigue. Internally, her condition is unstable. Her blood pressure indicates malignant hypertension, and her lab work shows a sharp, rapid rise in serum creatinine levels. At the bedside, the nephrology team performs a microscopic urinalysis. The sample reveals active urinary sediment, packed with dysmorphic red blood cells and distinct cellular casts. These casts form when massive, acute bleeding occurs deep within the kidney's microvasculature filtration system. Finding this combination of spiking creatinine and red blood cell casts indicates an organ-threatening nephritic emergency. Right now, the kidneys are failing in real time. To see why this failure happens, we must look past the ER monitors and zoom down into the kidney's microscopic epicenter, the glomerulus. Here, Y-shaped anti-dsDNA antibodies slam into the glomerular membrane and become trapped, activating the complement cascade. This inflammation forces mesangial cells to rapidly multiply. The resulting destructive crescent mass physically crushes the capillary loops, bringing blood filtration to a complete halt. Matching our patient's criteria, cellular casts, subendothelial deposits, and crescent formation to class 3 and 4 on this chart confirms acute proliferative lupus nephritis. Waiting for a definitive biopsy to prove this complexity creates a dangerous delay while kidneys are actively crushed. Standard clinical practice often dictates withholding aggressive drugs until a pathologist confirms the exact class of nephritis under a microscope. Every hour without treatment allows those acute cellular crescents to harden. They rapidly convert into irreversible fibrotic scars. This leads to a critical rule in modern rheumatology. When a known lupus patient presents with organ-threatening acute kidney injury, you never delay induction therapy to wait for a biopsy. Systemic glucocorticoids begin suppressing inflammation within 24 hours. Waiting for pathology results allows the necrosis to continue unchecked. Initiating immediate empirical treatment in these severe cases is a required protocol. In acute lupus nephritis, time is tissue. The first half of the immediate rescue protocol is high-dose intravenous pulse methylprednisolone, delivering 1,000 milligrams daily for 3 consecutive days. These IV steroids saturate the body's glucocorticoid receptors. This immediately shuts down deep inflammatory pathways like NF-kappa B, putting out the acute fire. Concurrently, the team initiates the second half of the induction rescue, mycophenolate mofetil, or MMF, targeting the underlying autoimmune engine. MMF blocks the IMPDH enzyme. Without it, autoreactive lymphocytes are starved of building blocks, freezing their proliferation. A demographic chart compares MMF against cyclophosphamide, showing MMF as the evidence-based choice, with statistical superiority for African American and Hispanic patient cohorts. This dual therapy approach attacks the disease from 2 angles. Steroids put out the immediate inflammatory fire, while the MMF disables the factory producing the destructive antibodies. Once the acute rescue phase in the ER concludes, the focus shifts to long-term regeneration and maintenance, governed by the latest American College of Rheumatology guidelines. These guidelines recommend a triple therapy strategy. By adding a third targeted biological agent to the steroid and MMF foundation, physicians can ensure a complete, sustained renal response. One option is belimumab. This monoclonal antibody neutralizes soluble BAFF, preventing the continuous baseline activation of B cells. The alternative third agent is voclosporin, a calcineurin inhibitor. It acts directly on the kidney's podocytes, functioning like structural braces on the microscopic slit diaphragms to stop protein leakage. This 3-drug approach moves the standard of care for lupus nephritis from merely preventing death to actively restoring pristine blood filtration and normal kidney function. Days later, the patient is stabilized, her creatinine levels are normalizing, and the acute renal crisis has resolved. Her recovery highlights 3 clinical rules. First, high-dose systemic glucocorticoids are the mandatory first step for life-threatening complications of lupus, exerting their effects within 24 hours. Second, never delay treatment for a biopsy in an acute presentation. Empirical induction therapy must outpace irreversible tissue necrosis. And third, mycophenolate mofetil is the evidence-based, demographically targeted induction agent for African American patients presenting with class 3 or class 4 nephritis. Mastering these rapid, evidence-based pharmacological interventions determines whether a patient suffers end-stage renal disease or lives a fully preserved, healthy life.